Here's a healthcare bombshell that's shaking up Malaysia's medical community. A major third-party administrator just mandated that thousands of bank employees can only receive generic medications for their chronic health conditions, regardless of what their doctors think is best for them. This isn't just another cost-cutting measure. It's a direct challenge to medical autonomy that has doctors, hospitals, and medical associations up in arms. But here's where it gets controversial. Is prioritizing affordability over individual medical needs the future of healthcare in Malaysia? MiCare Sdn Bhd, a healthcare administrator under the Hong Kong-based Zuellig Group's umbrella, has issued strict instructions to all healthcare providers in their network. The directive specifically targets employees of Hong Leong Bank Bhd and Hong Leong Islamic Bank Bhd, mandating that these workers can only access generic versions of medications needed for long-term chronic conditions. The company sent out official correspondence on August 12th to every clinic, hospital, and pharmacy within their panel network, laying down the new law. The message was crystal clear. Healthcare providers must exclusively prescribe and dispense generic medications for chronic disease management. Moreover, all prescriptions must only list the active pharmaceutical ingredients, completely eliminating any reference to brand names. This sweeping policy change specifically targets what the industry calls long-term medication, or LTM. Come September 1, 2025, this policy becomes mandatory across the board. And this is the part most people miss. The ramifications extend far beyond simple cost savings. In their communication to healthcare providers, MiCare attempted to soften the blow with diplomatic language. They emphasized their appreciation for the crucial role that medical professionals play in patient care journeys. The company framed their request for understanding and collaboration as an effort to achieve the delicate balance between maintaining quality healthcare and ensuring long-term financial sustainability. But here's where the medical community drew the line. The Federation of Private Medical Practitioners Associations, Malaysia, known as FPMPAM, fired back with a stern demand for policy revision. Their president, Dr. Shanmuganathan Ganesan, didn't mince words when addressing the fundamental issue at stake. He emphasized a critical principle that many outside the medical field might not fully grasp. While employers certainly have the right to determine the extent and scope of medical benefits they provide to their workforce, they absolutely cannot interfere with the sacred doctor-patient relationship. Dr. Shanmuganathan made it abundantly clear that clinical decision-making authority must always remain with the treating physician. Why? Because when medical outcomes go wrong, it's the doctor, not the employer or administrator, who bears the full weight of professional and legal responsibility. This isn't just about professional pride. It's about patient safety and medical ethics. The FPMPAM president highlighted a crucial concern that could keep any practicing physician awake at night. A rigid, inflexible generics-only policy creates significant risks for patient outcomes while simultaneously exposing doctors to unfair medico-legal liability for treatment decisions they didn't freely make. While FPMPAM acknowledged that cost-saving motivations drive such policies, they firmly maintained that physicians must retain the discretion to prescribe branded medications when clinical circumstances demand it. Their call for policy revision wasn't just professional posturing. It was a plea to safeguard patient safety, preserve clinical independence, and protect the fundamental integrity of medical practice. But here's the medical reality that makes this controversy even more complex. While generic medications are generally safe and effective for most patients, there are specific clinical situations where branded medicines become medically necessary rather than merely preferable. Dr. Shanmuganathan provided concrete examples that illustrate why a one-size-fits-all approach can be dangerous. Patients with specific allergies, those experiencing differences in bioavailability between generic and branded formulations, or individuals requiring absolute treatment stability may genuinely need branded medications for optimal health outcomes. To make this more tangible, consider diabetes management using SGLT2 inhibitors, a class of medications that help kidneys remove excess sugar from the body through urine. These drugs not only manage blood sugar levels but also reduce insulin dependency over time. For patients with chronic kidney disease or heart failure, SGLT2 inhibitors provide additional benefits by lowering risks of heart attacks, strokes, and heart failure episodes, while potentially slowing kidney disease progression. Now here's the kicker. If a generic version of an SGLT2 inhibitor fails to achieve the same blood sugar control as its brand name counterpart, the prescribing doctor remains legally obligated to prescribe the more effective originator medication to ensure safe and effective patient care. It's not about preference, it's about medical and legal responsibility. FPMPAM drove home this point with another real-world example. Certain generic antifungal medications have proven ineffective at clearing infections in some patients, while those same patients responded successfully to the original branded versions. In such cases, insisting on generic-only policies isn't actually cost-effective because ineffective therapy prolongs illness, ultimately driving up overall treatment expenses through extended care needs. And this is where the medical community's frustration reaches a boiling point. The Association of Private Hospitals Malaysia, or APHM, confirmed that multiple member hospitals have received similar policy updates from various TPAs on behalf of different employers, all implementing comparable generic-only mandates. While APHM acknowledges the legitimate need for cost containment measures in healthcare, their president, Dr. Kuljit Singh, emphasized a critical communication gap that's causing operational headaches. Dr. Singh stressed that the responsibility for communicating such significant policy changes should fall squarely on employers or insurers, not on healthcare providers who are simply trying to deliver patient care. He strongly urged employers to transparently inform their workforce that generic-only directives come directly from the employer level, not from medical recommendations. This transparency is essential for seamless healthcare delivery and prevents doctors and hospitals from being put in the uncomfortable position of explaining or justifying policies completely outside their control. But here's another complication that policymakers might not have considered. Not all medications actually have generic alternatives available in the market, creating case-by-case scenarios that will require individual assessment and handling. APHM member hospitals are now systematically gathering operational feedback and documenting the challenges arising from implementing such policies, potentially building a case study of real-world impacts. The Malaysian Medical Association, known as MMA, joined the chorus of opposition with even stronger language, describing employer and TPA interference in clinical decision-making as completely unacceptable. MMA President Dr. Kalwinder Singh Khaira emphasized that medical treatment decisions, including medication selection, must always remain the exclusive domain of qualified medical professionals working in consultation with their patients. Dr. Khaira pointed out a fundamental truth that should concern every Malaysian. When non-medical entities start dictating treatment decisions, it doesn't just undermine doctors' professional autonomy, it actively compromises the standard of care that patients have every right to expect and receive. But here's the most controversial part of this entire situation. The MMA has been warning about exactly this scenario for years. Dr. Khaira revealed that the MMA has long cautioned that unethical practices by some third-party administrators would eventually lead to situations precisely like this current controversy. Despite repeated calls over the years for government intervention and regulation, little concrete action has been taken to properly oversee these entities. The MMA issued yet another urgent call for swift government action to regulate TPAs and prevent further intrusion into healthcare decision-making. Their argument isn't just about protecting professional turf. It's about preserving a critical component of patient safety and maintaining public trust in the healthcare system. As Dr. Khaira warned, if such interference continues unchecked, Malaysia could face a cascade of negative consequences: poorer treatment outcomes, increased patient dissatisfaction, and a gradual erosion of confidence in the medical profession itself. This controversy reflects a broader systemic issue that's been brewing in Malaysia's healthcare landscape. Medical practitioner groups have been calling for TPA and managed care organization regulation for years. Back in September 2023, 13 associations representing medical practitioners sent an open letter directly to Prime Minister Anwar Ibrahim, claiming that cost containment measures by these healthcare middlemen have resulted in rationed and restricted patient care. These medical associations argued that the business models employed by many managed care organizations likely breach existing laws governing the medical profession, including the Medical Act 1971 and the Private Healthcare Facilities and Services Act 1998. Their concern? Such practices are systematically undermining the quality of medical care that Malaysian patients receive. As medical inflation became a major economic issue over the past year, the government's response has been to target healthcare providers, GP clinics and private hospitals, with policies like mandatory drug price displays and a planned diagnosis-related groups (DRG) reimbursement model that would standardize payment structures. But here's what critics find most telling. The government hasn't proposed similar policy reforms for the payers in this equation, the TPAs and health insurance providers themselves. The only significant regulatory action has been Bank Negara's decision to cap medical insurance premium increases at 10% for at least 80% of policyholders through the end of 2026. So here's the million-dollar question that every Malaysian should be asking. In the battle between cost control and clinical autonomy, who should ultimately have the final say in your medical treatment? Your doctor or your employer's cost-cutting administrator? This case involving Hong Leong Bank employees might seem like an isolated corporate policy decision, but it represents a much larger trend that could fundamentally reshape how healthcare decisions are made in Malaysia. Are we comfortable with non-medical entities making medical choices that could directly impact treatment outcomes? What's your take on this controversy? Should employers have the right to restrict medication options to save costs, or should medical decisions remain exclusively between doctors and patients? And here's the part that might surprise you. Are generic medications truly equivalent to branded ones in all cases? Or are we oversimplifying a complex medical reality for the sake of cost savings?